this webinar by Rare Ovarian Cancer Incorporated, more fondly known as ROC Inc. My name is Tasha Armour. I founded ROC Inc. in 2018 after my daughter was diagnosed with juvenile granulosa cell tumour at 16 years old in 2016. This is our very first informational webinar on granulosa cell tumour. I would like to begin by acknowledging the traditional custodians of the land on which we are meeting. I would also like to pay my respects to elders, both past and present, and extend that respect to any Aboriginal people that are present here today. I'd like to welcome Dr. Simon Shue, Head of Hormone Cancer Therapeutics Laboratory at the Hudson Institute of Medical Research.
G'day, hi.
Professor Peter Fuller, Head of Endocrinology Unit at Monash Health and Centre for Endocrinology and Metabolism at the Hudson Institute of Medical Research.
Hi.
And Professor Tom Jobling, Director of Gynaecological Oncology at Monash Health.
Good morning.
So we have Tom on audio, but we don't have a visual of Tom here today. So I'm just Rare Ovarian Cancer is a non-for-profit organisation formed in 2018 in response to a mother whose daughter was diagnosed at 16 years old with a rare ovarian cancer that had received no research. ROC Inc's vision is to create a greater awareness for ovarian cancer, its symptoms, and to ensure infants to women with rare ovarian cancer receive funded research for better options for treatments, intervention and prevention. Granulosa cell tumours are a rare ovarian cancer that has two subtypes, adult and juvenile. They are called adult or juvenile because of the cancer cells and not to the age of the person, though juvenile granulosa cell tumour does tend to affect females under the age of 30 years old. These tumours arise due to the dysfunction of the granulosa cells inside the ovary and are different from the more common forms of ovarian cancers, which stem from the surface of the ovary. Granulosa cell tumours approximately account for 8 to 10% of all ovarian cancers, affecting patients as young as infants to postmenopausal women. Granulosa cell tumours have an unexplained tendencies for a late recurrence, which can happen up to 40 years later and requires a patient to have a lifetime of monitoring. So that was some general information about granulosa cell tumours. What we want to do now is ask some questions. And back on. My first question is to Professor Tom Jobling. In the 90s, you were involved in the development of inhibin A and inhibin B proteins blood test for ovarian cancer detection. Over the last 20 years, inhibin A and inhibin B are still used as one of the main monitoring blood tests throughout the world for granulosa cell tumours. What other blood tests are helpful for monitoring granulosa cell tumours? And is there any future research developments for better blood tests to be able to monitor granulosa cell tumours?
Okay. Well, first of all, I think it would be appropriate to acknowledge David Robertson as the discoverer of these things. I was a passenger on the journey, and it was an interesting time because the inhibin test was found to be quite useful for other types of ovarian cancers and not just granulosa cell tumours. So the test itself is incredibly sensitive, and it is quite specific for what we call stromal tumours of the ovary. So if you think about the ovary as a bit like an orange, it's got a skin on the outside, it's got a meaty bit in the middle, and it's got some seeds right in the middle of it. That's what an ovary is like. And the commonest ovarian cancer is the epithelium, or the one on the skin on the outside. Granulosa cell tumours are the stroma, if you like, but there are a few other tumours that also occur in that part of the tissue. And in young girls, germ cell tumours occur. That would be the commonest tumour. But if we restrict our conversation to granulosa cell tumours, the test is actually, we found in the research that the Inhibin assay was able to detect the tumour about 6 months before any imaging. And indeed, the great thing about the test is that when it starts to rise, we can accurately predict that there is a recurrence before any imaging. And I noticed on one of the submitted questions, they talked about other tests and things like that. Well, PET scanning, CAT scans, MRI scans, ultrasound, you name it, none of them are as sensitive as Inhibin. Whether it be Inhibin A or total serum Inhibin, the Inhibin A assay that we have at the moment, the Inhibin B assay at the moment is actually pretty good. And we've found it very useful in monitoring the response to treatment and to how patients are in general. In terms of people will be aware of anti-Mullerian hormone and its role, and there have been some publications on the use of both Inhibin B and anti-Mullerian hormone, or AMH as it's written on the forms. I haven't found it clinically to be any more useful, so I must say I don't actually use the AMH assay in that setting. That's my answer.
Oh, thank you, Tom. The AMH, so I know there has been a lot of discussion. My daughter diagnosed with juvenile granulosa. We use AMH in her blood tests as well. So that is interesting that you're not using.
Sure. Well, I mean, just to expand on that a bit, if you look at both of the hormone, or both of those assays involve measuring proteins which occur in premenopausal women anyway. It's much easier in postmenopausal women, but in premenopausal women, the AMH level will fluctuate depending on, and Peter might be better to answer some of this question too, but certainly AMH will vary depending on follicle counts and how many oocytes are left in the ovary, and we use it more in the setting of women who are uncertain as to their fertility and what their ovarian reserve might be. In terms of Inhibin, it will fluctuate with the normal menstrual cycle too. So, it's a little more difficult to interpret in the premenopausal patient.
So would you say then having your blood test done at a particular time of the month each time for the premenopausal women would be better?
Oh, well, look, theoretically that might be okay, but in practical terms it just doesn't seem to work all that well. But I've not bothered, because in general terms with tumour markers, regardless of what the tumour might be, whether it be breast, colorectal, ovarian, it's not a one-off test result which is important, it's the trend. So if you see none of these tumours, especially where a tumour doesn't grow rapidly, none of these tumours grow, or GCTs don't grow rapidly. So it's really the trend in the level of the test that is important. So especially in a premenopausal woman, if the inhibin's a little bit elevated today, but it drops again in 3 weeks' time or 6 weeks' time, well, then you can rest assured it's okay. If it's inexorably going up, well, then that's when it becomes a bit more important.
Okay. Thanks, Tom. That was great.
That's right.
Explaining that. So I'm going to go on to our next question, which is for Dr. Simon Chu. Can you please explain about the world's first and largest juvenile granulosa cell tumour research that is about to start? What is the research about, and what are the outcomes you hope to achieve?
Thanks, Tasha. So I guess, given the rarity of juvenile GCT, so for those in the audience, I guess for granulosa cell tumours, 95% of granulosa cell tumours are actually of the adult type and characterised by a mutation in a gene known as FOXL2. But for juvenile GCT, which are only 5% of all GCTs, there really is not much known about the genetics, what causes the tumours, what are the genetic changes that are causing the tumours. And the reason being are because of the fact that these are very uncommon. And so collection of tumour material to analyse, if you like, in most centres around the world, I guess the difficulty there is that maybe they only see one or so every number of years. And so what through ROC Inc, as well as our own collection, where we have in the past collected some juvenile GCT, we're embarking on a project whereby we're going to perform sequencing of the genome of these tumours and be able to compare those to the normal DNA sequences of the patients in order to identify mutations that either are causing the tumours to arise, much like the FOXL2 mutation that we know causes the adult GCTs to arise, but also potentially out of that information that we see, the mutation information, that we may be able to find genes which can be targeted by drugs and be able to develop more personalized type medicine in order to be able to treat those tumours in a better way than what we are at the moment. And so our collection of tumours, if you like, has now become the world's largest collection, or one of the world's largest collections of these tumour types, and ever expanding. And we're able to now hopefully be able to collectively put all of those together, and then statistically that just improves the actual outcomes. So we're able to definitively, with a larger number of tumours, yes, that gene is what causes this tumour to arise, or yes, those genes are what we can develop drugs to target in order to treat.
So the more tumour samples you can get, as well as, because I believe that to be a part of the research, you need the tumour samples as well as DNA in the way of saliva kits. So
that's correct. Yes. So for those, and there are some in our audience perhaps who've agreed to provide their tumours to us and have sent them already to our institution. But along with that, we've also sent out, and I'm hoping some have already received them. They're just a little saliva kit in order to spit in a tube, if you like, and by doing that, we're actually able to access normal DNA because, especially for those in the audience, there's a real difference between what is in your normal DNA and in the tumour DNA, because mutations do arise from cells that grow very quickly, and we're able to identify what the differences are just by comparing the genome sequence.
So that's comparing the tissue tumour samples and then the DNA, and the differences then can result in identifying the mutated genes.
That's correct, yeah. So we call that, sometimes when you're reading, you might see the terminologies germline DNA, and that is your normal DNA sequence, so what you were born with. But then you also sometimes see somatic mutations, and they're mutations which have arisen due to, usually due to they're not necessarily what you're born with. Well, they aren't what you're born with. They'll arise spontaneously.
And that's what this GCT is somatic.
So the FOXL2 mutation in the adult GCT, for example, is a somatic mutation. So it's a mutation that's specific only to the granulosa cells. And so if you compare that to other cells in the body, the other cells in the body do not have the mutation in the FOXL2 gene, but it's only in the GCT cells that you have that mutation.
And then that's what part of the juvenile granulosa research is about, is that we don't actually know what the mutated gene is. So by having this research that you're doing, so we can find out what that mutation is.
Yeah, that's correct. And I guess, you know, we have some circumstantial evidence as well as smaller studies that have found certain mutations that may be linked to juvenile GCT, but because the numbers have been so small, it's hard to say so conclusively, and so that's why we need to expand the numbers and also to do a full genome sequencing research project, if you like, because prior to that, they've all been more targeted. We believe that this gene might be involved, and let's have a look at this gene. And so they're only looking at specific one gene or a number of genes at a time. But this way, we can actually look at the whole genome. So all the 20 to 25,000 plus genes we can analyze.
Wow. So if anyone is interested in being part of the research, there will be more information at the end of this webinar at how you can get in contact with ourselves and Simon to be able to be a part of the research and help towards finding answers for the future. So the next question I have is for Professor Peter Fuller. It's a bit of a long one. And a bit generalised. So Peter's going to have a look at a few different things, I think, on this answer as well. So granulosa cell tumours and its current treatment is generally surgery first, and then it gets a little cloudy for what the next step is, as each country around the world have different ideas about if you have chemotherapy, and if not, if it is offered, at what type of different chemotherapies are offered. There's not a lot of information or proven research to show that chemotherapies that are offered even work for granulosa cell tumours. You and your team have been working on and submitted a grant for research into possible more targeted treatments for granulosa cell tumours. Can you explain more about this?
Thanks, Tasha. Most of the people listening to this webinar will appreciate that one of the problems in the area, if you look back historically, is that granulosa cell tumours have always just been lumped in with ovarian cancers in general, with epithelial ovarian cancers. And so approaches, strategies, treatments have been based on that tumour type. And I think what has become very clear over the last decade or so is that this is really a distinct disease. It comes from the same organ, the ovary, which Tom described elegantly before, but the cell type and the behaviour of these tumours is different from the common epithelial ovarian cancers, and so it needs different strategies. And there's not a lot of compelling evidence that the conventional treatment of ovarian cancer is appropriate. It probably works because there's a non-specificity about it to some extent, but it's clearly not being targeted or as efficacious as one would wish. And Tom might talk to the current approaches, particularly around endocrine manipulation, but even there, where there have been published studies, there's not a compelling evidence beyond specific individuals. So what we're driven by is single patient reports by one clinician's experience of one or two tumours, not by a strong evidence base. From a research point of view, given that this is a different disease, and as Simon's articulated, we'd like to identify targets, which in this context means changes in the tumour DNA, mutations that lead to the disease, and see if we can block those. And FOXL2 defines the adult type of granulosa cell tumour. It's present in all of the tumours, whether stage 1, cured by surgery, no recurrence, or by stage 3 with advanced disease and not necessarily positive outcomes. And so clearly FOXL2 is part of the story, but it's probably not what's driving a tumour to more aggressive behaviour. And so part of this program is trying to identify other mutations in the tumours that are driving this aggressive behaviour, and then seeking to target those, hopefully with known drugs, but if not, by developing drugs. At this stage, you'd say on the basis of limited studies, there's not a clear emerging candidate here, and we're looking at different approaches to address that question, and also looking at other strategies, novel strategies that don't necessarily relate in any way to epithelial ovarian cancer. And so part of the program is continuing some work that Simon has done over the last few years, looking at genes that are at high levels in these tumours as opposed to normal tissue, and seeing if they can be targeted. And probably Simon should comment on the specifics of that work. Simon, did you want to expand on that?
Oh, sorry, I missed so we've been looking at through our analyses in the past, targeting a couple of proteins, particularly for the adult form of the tumor type. And what we've discovered is, in fact, that certain pathways are activated or stimulated in these tumors, and so by being able to shut those down in some way or form using particular drugs, that we're able to stop the tumors, at least in the dish, from growing. And so we've been interested in looking at novel combination therapy by targeting these pathways by two hits, a two-hit type of approach, whereby if you shut down one pathway and then you shut down another one, then the cell will naturally want to die. And so that's what we're attempting to do. We've been doing so in the laboratory, looking at cells that are currently in the dish, but then we're hoping to also move into some animal models in order to be able to then move them into humans down the track. So it's exciting work that we're doing in that realm, and we're looking at as part of this program to try to we've identified one particular program, which one particular protein, which we believe sensitizes the tumors to that second hit. And so part of the program is to look at a whole drugs that are currently being used in the clinic as a potential second hit combination partner. But we're also, part of the program is to look for novel hits as well, which we don't know anything about yet, and that's using technology, new age technology, if you like, and many of may have heard the term CRISPR. We're going to be using that as part of the project as well. So so we really do believe that it's the combination approach that will lead to much more targeted and personalized therapies down the future.
So, Tasha, it might be appropriate to ask Tom just to comment on the kind of state of play with the use of aromatase inhibitors, which seems to be gaining some popularity despite perhaps no systematic studies yet.
It is interesting to track, if you like, a patient's disease status using hormone therapies, and the two main ones that we use, of course, are progestogen and aromatase inhibitors, whether they be letrozole or Arimidex or any of those aromatase inhibitors or receptor blockers. And it's interesting to note that for reasons that are totally inexplicable, some patients will respond for a while to Provera, for instance, or medroxyprogesterone acetate, and their levels will fall and they'll sit there for a year or two and then they'll start to climb despite the usage. And then you swap them over to a different one, for instance, an aromatase inhibitor, and then they'll respond again. And I don't understand why that should be, but it does seem to occur. So the idiosyncrasies of hormone therapy are a little bit inexplicable, in my opinion. So, Peter, I was rather hoping you might be able to give me some guidance on that. But nevertheless, I'm sure most people who have recurrent will be offered hormone therapy, because to go back to the chemotherapy side of things that you very, very nicely pointed out, it's been a shotgun approach over the years. And if you ask a medical oncologist what drug are you going to use, they'll almost certainly go carboplatin paclitaxel. Oh, that's good. Well, it's not going to work all that well, because we haven't treated a patient with chemotherapy for years, because in our experience it just doesn't work very well at all. And mostly it's hormone therapy or surgical treatment. And there was a question on the right here, which is about lymph nodes. We've had patients with lymph nodes which we've had to resect. They grow slowly back again. There's no point really in seeing whether there's any other nodes, because you're not going to be able to surgically resect all lymph nodes. So the therapeutic options, we prefer, of course, the minimalist approach, which is the hormone therapy. But it is very much try it and see how it goes. There is no systematic approach which seems to have been better than any other approach. And most of it's relatively low toxicity, so it's relatively well tolerated and can be used fairly long term. I don't understand why they develop a resistance, if you like, but it does seem to occur in the evolution of the disease.
So that is, I guess, a lot of you saying with the resistance and not knowing. I guess a lot of parts of granulosa cell tumour is the unknown, and why the research is so important. And I guess that we've seen so many people jump online here today for looking at granulosa cell tumours and what's happening in the future, and why I wanted particularly you three guys on here as leading experts for granulosa, so that people can see that the future is towards research, and we need to start research, and we all need to participate in helping for that. So we need to be supplying the tumour samples, the DNA, and unfortunately at this stage we look like we need to be, raising the money towards the research for answers for ourselves for the future. So the next part we're going to go on to is, and we're getting lots of questions down the side here as well, so I'm going to hand it over to Dr. Simon Chu, Professor Peter Fuller and Professor Tom Jobling to go through some of the questions that have been asked. Of course, if the question is to personal clinically, then obviously they can't respond to that, but they can give general answers. And they're going to go through those questions. Any questions we don't get through today, as we have lots of questions, we will endeavour to get back to you with a written answer in the next couple of weeks. So I'm going to hand it over to you, I think, first, Simon, to take lead on the questions.
Okay, thanks, Tasha. So, yeah, thanks to everybody for submitting your questions, and there are many of them. And so, unfortunately, I'm confident that we're not going to be able to get through most of them. There are a number of questions here that we will hopefully be able to address, and we're going to be trying to do so more in a general way rather than actual individual specifics. But there is a question here that maybe Tom can help answer. It's a question from Marie regarding a recently diagnosed recurrent GCT after 25 years of after her initial diagnosis, having no signs or symptoms for all that time. But she's got she has recurrence in the liver and spleen, and then mentions that she's had carbotaxol to little avail, and is now on fulvestrant injections and letrozole. Any suggestions on the cyberknife procedure or any other treatments such as that, and neuropathy and so forth? And I guess there's a number of questions there that have asked a question about this cyberknife as well. So I don't know if you want to discuss that.
Look, it's an interesting question. Cyberknife is just a way of delivering focused radiation to the liver in this circumstance, and the aim is to get a high ablative dose to the liver metastasis with minimal delivery of radiation to normal liver. You have to obviously consider what the resectability is in terms of surgical operation as well. And my liver colleagues tell me that you can resect up to 70% of the liver, which is pretty interesting, but you need to have two segments of liver next to each other that can be preserved, and you need to have both obviously inflow and outflow of blood supply, and obviously a connection to the common bile duct. Having said that, we have had a number of patients that have had liver resections, and if the disease is multifocal right throughout the liver, the use of a cyberknife is potentially an option. But there are other things that have to be considered, such as damage to surrounding structures, such as small bowel, the stomach itself, and most of the time they can deliver it in a pretty directed way. The health of the liver is also important in terms of, as long as you don't have cirrhosis or other other liver conditions, but most of the time they can deliver fairly high doses in relatively few fractions. So my radiation oncology colleagues tell me that they can give 16 to 20 gray of radiation, which is a reasonable dose, in about 4 to 6 fractions. So in other words, 4 to 6 deliveries. In terms of surgery for the liver metastases, obviously, the liver does recover quite well, which is interesting. And as I said, we have had to do recurrent liver resections on some of our patients. In terms of your question about neuropathy, well, unfortunately, neuropathy is associated with paclitaxel and carboplatin. It can take about 18 months to get the best recovery. There are no known antidotes to it, and it is troublesome, and you have all my sympathy. But there's not a whole lot you can do. There are no specific drugs that can minimize those symptoms. One of the things that I've spoken to Simon about is the observation in terms of alternative therapies, is the observation that when you operate on granulosa cell tumours and the multifocal deposits that we find in the abdominal cavity, they're highly vascular. Hence, intuitively, we thought that if you could look at treatments on vascular endothelial growth factor receptors and blockers such as bevacizumab, that might have a role. And I know that Simon is doing some research on that, which I'm going to drop you in now, Simon, on talking a little bit about that, if you don't mind.
No, that's yeah. So the aromatase inhibitors, the VEGF receptor inhibitors. VEGF is an important growth factor that that encourages vascular or blood capillary formation. And the idea, I guess, of using these inhibitors would be to effectively strangle the blood supply, and then hopefully be able to remove the remove the what is feeding these tumours, if you like. And so that's a pretty exciting area to look at. And I think that too, in fact, if you look at a couple of the other questions that have come through regarding aromatase inhibitors, and particularly for those that may be estrogen receptor negative tumours, that maybe that's where aromatase inhibitors might be working, because aromatase also encourages, or estrogen also encourages the formation of these blood vessels. And so it's possible that it's having an effect on the blood supply in that regard as well. So it's certainly an area that we're exploring and like to explore further. The difficulty of doing that in the laboratory, of course, is that a lot of our research works with cell lines that do not have a blood supply. We just provide the nutrients through a media that they grow in, and so then you have to move into sort of in animal models and so forth, and that's challenging in itself. But it's certainly an area that we're very interested in exploring. I don't know if Peter wants to add anything further to that.
No, the comment I was going to make, since we've raised the issue of fulvestrant and letrozole, and just emphasize that fulvestrant blocks the estrogen receptor very potently, and letrozole blocks the production of estrogen. And these are strategies that are used routinely in the management of breast cancer, where in the context of estrogen responsive breast cancers. So there's quite an experience with this. But I noticed with a number of the questions, somewhat predictably, that women who are particularly premenopausal or perimenopausal subject to this therapy will have a dramatic menopause and all the potentially adverse symptomatology that can come with going through the menopause. And obviously there's a contradiction, because you don't necessarily, you're not going to give somebody estrogen to deal with those symptoms if they're on drugs blocking estrogen. And so in this context, there are a range of strategies that are now used in the breast cancer field to deal with those side effects. And I would encourage people, women, to seek out that sort of advice in their own centre, looking perhaps to the breast cancer group to see how they're locally managing these things. We have at Monash, we have a dedicated clinic attached to the menopause clinic to look after women who are on these agents. And I think most centres are probably doing that now. So I think there are solutions that can be found perhaps in other areas, if you will, of the hospital or the health service.
Thanks, Peter. So there's a question from Sharon regarding, she's been 9 years since diagnosed and she's now no evidence of disease. Her oncologist has said that they don't need to see her anymore and no need for any more testing. So she's asking, should I be concerned? What's your opinion on that?
Well, I'll address that. It's a very reasonable suggestion that the oncologist has made. The problem with routine surveillance on any cancer, especially a relatively low-grade cancer like granulosa cell tumour, is that the assumption is that if you have a checkup once a year or however often, that you'll pick up an early recurrence and that will translate into an improved long-term outcome, because I've nipped it in the bud and I'm going to give you some treatment now that's going to make you well forever. It's a nice idea, but the reality is that if you speak to the epidemiologists and the biostatisticians, it doesn't actually, it's very difficult to support in any circumstance. So it raises a whole number of questions. The short answer is that I think it's entirely reasonable for you to stop follow-up. The better answer might be to say, look, if you get any symptoms, then certainly contact us straight away and we'll see you immediately. It's really difficult because, of course, the anxiety associated with not having a checkup is quite significant in my experience, in my own patients. The anxiety that occurs when a patient turns up for an appointment for a few days beforehand, and then they get reassurance, of course, which is great. It's hard to factor that in, and everybody is different. So I wouldn't be rushing to get a new doctor who's going to just see you once a year and say, you're okay, you're fine. I think to be able to say, well, look, these are the symptoms you should look out for. If they occur, contact us. And we talked a little bit about before about high levels of estrogen producing symptoms. Well, that might be the case if you get recurrent granulosa cell tumour. Any other symptoms will be just those of intra-abdominal cancer, which will be distension, and they're all very non-specific. So it's a difficult clinical situation in terms of advising patients. But I think if you get any particular pain or unusual symptoms, expeditious review and investigation is appropriate. But how long do you keep seeing a patient for? You know, do you see them once a year for 20 years? It just kind of doesn't make a lot of sense.
Thanks, Tom. A question from Melanie regarding if there are any advances in genetic research, which means that the FOXL2 mutation will offer the possibility of a cure for those GCT or the tumours that carry that mutation. So Peter, do you want to address perhaps that question?
Well, it's a great question. Obviously, the fact that these tumours, the adult GCT, have a unique mutation, and this mutation has not been found in any other malignancy. So it's a very curious finding. The problem with the FOXL2 mutation is it's not clear that it's possible to develop drugs that exploit that mutation, that block whatever's happening. It's part of a very large family of proteins that regulate genes and that are very similar in structure. And so the notion of designing a drug to block this is challenging. So I think whilst one can't say it won't happen, it's not easy, and there hasn't been a lot of work on that for that reason. I think the other thing, going back to my comment much earlier, is that FOXL2 is really critical to start the process of developing into a tumour, but there are obviously other factors, other changes, probably changes in the tumour's DNA that are driving the aggressive tumours, which are the ones that we really need to develop the therapeutic options for. Clearly, the stage 1 tumours, which have the mutation, are surgically treated and cured. That's terrific. So I think the answer will lie in identifying the subsequent, in genetic terms, hits, the mutations that the tumour requires. Targeting those are probably going to be more rewarding than targeting FOXL2. But science is moving very rapidly, and I wouldn't necessarily exclude something coming there.
And now a question from Catherine regarding the role of immunotherapy or targeted therapy for treating juvenile GCT. How much do global centres of excellence share advances between themselves, and what can we do to encourage this? Is there any difference in the way adult GCTs and juvenile GCTs are treated, and should there be? And what more can we women do to help any advances in the research? So it's an interesting question on immunotherapy. I suppose, in a sense, the fact that many of these tumours are vascular might make immunotherapy quite amenable for treatment. Would you agree with that?
Yeah, look, I mean, immunotherapy is the brave new world of oncology, as we all know, and there's For instance, in normal ovarian cancer, there's been no new chemotherapeutic agent since 1993, which I think underpins the whole issue of the fact that we've run out of options in that regard. We are doing research on immunotherapy with normal ovarian cancer, and of course, granulosa cell tumours will be no doubt looked at some stage. I mean, the targeted molecular therapies are of course going to be pretty attractive because it makes more sense than just using a sledgehammer approach to every tumour. In terms of precision medicine and genomic identification of patients' tumours who are going to respond, or which are going to respond to appropriate treatments, that's where we're heading now. I mean, immunotherapy requires the identification of an appropriate target, if you like, or a checkpoint inhibitor and things like that. To the best of my knowledge, no one's looked at granulosa cell tumours because they do have such a good prognosis most of the time. The intermediate grade tumours or low grade tumours such as granulosa do make therapies difficult because, of course, chemotherapy traditionally works on different parts of the cell cycle which require it's a high-grade tumour responds better to chemotherapy than a low-grade tumour, for instance, and that's why chemotherapy, in my opinion, with granulosa cell tumours is a bit of a waste of time. The other things about the tumour, just digressing for a moment, is that because I saw one of the questions was about PET scans. Well, in my experience, PET scans don't work all that well because they require high metabolic activity to take up the tracer which we use for the imaging. So the whole problem with granulosa cell tumours, if you call it a problem, is that because of their low-grade nature, they do defy certain other therapeutic options. Immunotherapy makes sense, and I'm pretty sure there's no one looking at it right now for GCT, but it clearly in some patients where they de-differentiate, it would be a very interesting and useful approach. So I don't think we can, I think we certainly should embrace it where possible. As we know, some patients, when their tumours are becoming more frequently recurring, they do tend to have a slightly more aggressive clinical course and therefore would seem to be perhaps more appropriately looked at for immunotherapy. And there are plenty of centres that are looking at immunotherapy.
So Simon, I guess just reinforcing what Tom said, I think immunotherapy has really been a game changer in some types of cancer, and others would describe it as a sort of disruptive technology because it really has a completely different mode of effect. It's really trying to supercharge the patient's immune system to attack the cancer cells. And we're still really learning what are the rules, what governs success or failure with these agents. And the problem with obviously with the less common cancer is it's very hard to immediately address that, as opposed to bowel cancer or breast cancer, which are relatively common, and so people can immediately set up trials. I think with ovarian cancer, the results initially have been disappointing with the common ovarian cancers. Granulosa cell tumours don't have a large burden of mutations, which is said to predict a better response to these therapies. But as Tom was alluding to, you would feel that in advanced or aggressive granulosa cell tumours, it's something that would be reasonable to try, but we have really no idea whether it will work or not. And I guess the other extension of immunotherapies is the development of CAR T cells and a sort of personalised supercharging of your immune system. And again, I think it's an open book. We may see something emerge, we may not. It's really last couple of years that all of this has come into play.
And regarding the, I guess that question also asked about whether, I suppose, laboratories that research these tumours share their findings with one another. I think to answer that question, as often as we can, we do meet up at various conferences around the world, whereby usually there is a gathering of the different labs. And mind you, around the world, there's not too many labs that are researching granulosa cell tumours and in particular juvenile GCT. But we do know most of the centres that are, and in fact we mostly all collaborate in one way or another. And so in that way there is information shared, there are ideas exchanged, and in terms of the collaborations that are formed, we are really all trying to work with one another rather than against each other, which does occur in various other forms and types of research. But for GCT, because we're a much smaller community, we do tend to collaborate worldwide. So there are various centres in Canada and in Finland and New Zealand, us here in Australia, and the US and so forth. And so it's a small but vibrant and active community. Just looking through a couple of the other questions. There was a question regarding, is there any suggestion that recurrences will be more aggressive if the patient has taken aromatase inhibitors?
Who do you want to answer that?
I'm not. Yeah. If Tom, are you there? I think Tom might have dropped out.
I think he has. There, Simon. At this stage, no, Tom's mic is off. Tom wants to put his mic back on.
Tom, are you there still or not?
So I guess I'll try and sort of answer the question in general terms, is that tumours evolve and they acquire mutations, and the recurrence probably hasn't been created by the treatment, but the cells that recur are probably resistant to the treatment because you've effectively selected, you've destroyed the cells that won't respond, but a group of cells that have acquired new mutations will continue to grow out. And so it's probably not changed the pattern of what was happening. It's just perhaps more dramatic because instead of things moving forward, you've had an improvement, and then those other things that were coming anyway have emerged. So I don't think there's any reason to think that the treatment per se is causing the problem.
Thanks, Peter. There's been a few questions regarding environmental factors, what causes the FOXL2 mutation, is there anything in our diet or so forth that can lead to it, or can we take to prevent? I guess in the most generic way, how do we answer those questions? I suppose in terms of, for the FOXL2 mutation, we have absolutely no idea how that or why that mutation occurs. For various other tumor types, there are these mutations that we call them hotspots, whereby they tend to be the same mutation that occurs in the same spot, and they can be quite common for other types of tumor types. And for the adult GCT, that's the situation in the FOXL2 gene, but we don't know what actually causes it. It's an area of research which is not as easy to really find out about. But what about things like, do we know anything about other risk factors, Peter?
So there have been in the past quite a lot of population studies looking at that question, and they really failed to identify factors. Now, obviously, when something's relatively uncommon, it's going to be hard to identify in each individual case or each individual patient what was the causative factor. But insofar as it's been studied, nothing has clearly emerged. And you come back, particularly in something that's uncommon, to the fact that the cells in our body are always continually acquiring mutations that are then usually removed because the cell has a lifespan and it disappears and nothing else happens. So it's probably, potentially, it's a bit like being struck by lightning. It may be a 1 in a million chance this will happen, and it happens to 1 in a million, or whatever the number is. We don't have any other reason. It's curious because it's very specific. Mutations elsewhere in the FOXL2 gene don't cause this. So you end up kind of with bad luck as the explanation, which is, of course, very unsatisfactory as an explanation, but probably statistically correct.
Mm. And we have a question on whether beta-HCG or birth control pills have any role in the management of GCT. Some women have used both with good results, but we can't understand why. I don't know if we can answer that one. Can we, Peter? Is Tom still there, or is he gone?
I don't know. Can you hear me now?
Oh, yes, Tom.
Yeah.
Hi.
Sorry. I had a bit of an IT issue here that I was completely incompetent at. Sorry, my dog's just run into. Basically, the beta-HCG I'm not sure about. Birth control pill, in terms of being therapeutic, or at least protective, has been, of course, something which we've looked at with genetically based ovarian cancer. So we know that if you're on the combined pill for more than 4 years, you've got a 2.8 times reduced risk of ovarian cancer, but that's epithelial cancer. I am pretty sure there's no data on the use of birth control pills either as a prevention of, or a preventative thing, or being protective, or in fact increasing risk. I can't imagine that it would increase the risk, Peter, because, you know, in terms of the physiological effect, in terms of the menstrual cycle and the feedback loop with the hypothalamus and pituitary, can you imagine how it could possibly be deleterious?
No, and I agree. I think that there has been a number of studies that have looked at this possibility and have found, when the study is done properly, that there doesn't seem to be an effect.
Right.
Thank you. Tasha, are you any other questions? Or, I mean, there's a lot of questions along the side here, but I think we're almost running the time.
Yeah, we are running out of time. And I do thank you. I thank everyone for submitting all the questions, and we will go through some of that. I have a couple things just to go through before we finish up. And if I get on to the next slide here, we've been talking about all the different therapies and lots and lots of questions, and a lot of our questions stem from not knowing the answers for the future and towards the research. So the Hudson Institute of Medical Research, located in Melbourne, Australia, needs granulosa cell tumour samples, both adult and juvenile granulosa, and the supply of DNA saliva kits to go with that. And if you're able to and want to participate in the research, you can contact myself. My email is Tasha, Tasha, at ROC Inc, ROCINC.org.au. If you are located outside of Australia, your information will then be passed on to either Sue or Linda to contact you and take it from there. Together, we can create change for the future. I think we need to be participating to help researchers to get the answers for the future. And so how else can you help? By donating. Did I have the slides back to front then? I haven't got my glasses on. By donating towards the research. You can raise the money through fundraising yourself, trivia nights, bake sales, office raffles. You can also try rock painting for awareness with our Facebook group, Rock for Rock. So far, ROC Inc, in our short period of time, we've raised over $50,000 towards research. There is currently a grant application in with the Australian Government Medical Research Future Fund for Granulosa, for all Granulosa Cell Tumour research. That'll be announced in the next few months. So fingers crossed we are awarded. So Simon, Peter and Tom, part of the team on that grant there, can continue their work for research. I would like to thank our special guests today, Dr. Simon Chu, Professor Peter Fuller, and Professor Tom Jobling, for taking your time out of your day to talk to us about granulosa research and answering some of our questions. It really has been very informative. I would also like to thank everyone that participated in our very first webinar for ROC Inc. So thank you for taking time out of your day. A big shout out to our web guy, Doug, which I've stressed out for the last week or so. He's done a great job setting up this webinar. For any of the questions that have been submitted, we had an email, dedicated email for questions coming in, and we can see by the side there was lots of questions getting sent as the webinar continues. We will endeavour to answer those over the next couple of weeks, and that'll be through, we'll be writing that responses. Also, some of the slides today will be in the handouts. So if you want to download any more information, including information about our Facebook Rock for Rock group, you can do that in the handouts. And we're just about to wrap up, I think right on time, hitting at 9 o'clock. Nice to see that, nice and punctual. So thanks once again for your time. I really, really do appreciate you coming on at such an early hour this morning here in Australia. I think elsewhere you're still on the 29th, which is actually Rare Disease Day. So quite good that we've got the webinar featured on such a rare disease for Rare Disease Day around the world. So thank you.
Thank you, Tasha. Thanks, Tom and Peter, and all those in the audience. And sorry, we weren't able to get through all those questions, but we hopefully we're working very hard to improve those who have had or have this disease.
Thank you.
Thank you.
Thank you. And that's a wrap.